This is a chest radiograph of an elderly woman who presented with hemoptysis. The frontal film shows obscuration of both the right heart border and the right hemidiaphragm, indicating loss of silhouette from collapse of the right middle and lower lobes. There is clear evidence of volume loss, demonstrated by rightward shift of the heart and mediastinum. These findings suggest combined right middle and right lower lobe collapse, most likely secondary to an obstructing central lesion. CT performed the following day confirmed collapse of the right middle and lower lobes with an obstructing mass in the region of the bronchus intermedius, consistent with a central bronchogenic carcinoma. The reconstructions show inferior displacement of both the minor and major fissures and a central mass obstructing the bronchus, causing lobar collapse distal to it. The key teaching point here is that combined right middle and lower lobe collapse occurs when there is obstruction of the bronchus intermedius, which supplies both lobes. The resulting volume loss causes inferior displacement of both fissures. The minor fissure falls below the level of the major fissure, while the major fissure becomes more vertical and extends superiorly toward the hilum. The composite appearance of these displaced fissures and collapsed lobes produces an S-shaped opacity, especially when there is a central mass, as seen in this case. The right hilum is pulled inferiorly, and the descending right interlobar artery is obscured. Mediastinal shift to the right further confirms significant volume loss. It is important not to confuse this appearance with a right pleural effusion. In an effusion, opacity tends to be higher laterally, while in combined right middle and lower lobe collapse, it is more medial and central. A helpful radiologic concept is the double lesion sign, which refers to collapse of two non-contiguous segments or lobes, implying more than one obstructing lesion. In this case, however, both affected lobes are adjacent and share a common bronchial supply, so a single central lesion is the likely cause. In terms of management, when lobar collapse is due to mucus plugging, pulmonary toilet and bronchoscopy to remove the obstruction are appropriate. However, in an older patient with hemoptysis and imaging findings suggesting a central mass, bronchoscopic evaluation and tissue diagnosis are essential to confirm malignancy. The collapse should always be followed to ensure resolution. Persistent collapse strongly supports an underlying obstructing carcinoma. In summary, this case shows right middle and right lower lobe collapse secondary to an obstructing central bronchogenic carcinoma, with classic features including loss of the right heart border and diaphragm, mediastinal shift, fissural displacement, and an S-shaped opacity, a high-yield pattern that should prompt consideration of a central endobronchial tumor.